is Christine McCartney. I'm the Director of the National Centre for Immunisation Research and Surveillance. And we're sitting here in a room of about maybe 40, 50 people at the NCRS. And we're also broadcasting live to many more people across Australia who've hopefully joined in. Just to check for those who have joined in remotely, you will be seeing the screen, but you will still not be seeing the presenter, just so you're all aware. You'll be hearing a voice and you'll be seeing the screen, but our technology does not currently quite reach to seeing the presenter. We'll be getting there soon though. So firstly, I would like to start our seminar off by acknowledging the traditional owners of the land on which we're meeting today, the Darug people, and to pay my respects and all of our respects indeed to their elders past and present, and indeed any Aboriginal people who are in the audience with us today. It's a great honour to meet on the land of the Darug people. So I'm very excited that we have a seminar today that includes 3 speakers, and we are incredibly honoured to have a visit today from Associate Professor Julie Bettinger from Canada. So I've already told Julie that my own mum's from Canada, but that's a completely separate aside. Julie, is a very esteemed researcher and who's been known to some of us for a number of years, but indeed, we've just really excited to have you here today, Julie. As I mentioned, she's an associate professor at the University of British Columbia on the west coast of Canada, and she has worked for quite a long time with these 2 networks, the Impact network as their senior epidemiologist for a number of years, and also with the Canadian network for vaccine safety surveillance, Canvas, which she's going to tell us quite a lot more about today. So we're very, very honoured to have you, Julie, and we're looking forward to your talk. We'll have a few questions after Julie's talk, and then after the other 2 talks that relate both to Impact and Canvas, we'll have a few more questions after that. But firstly, welcome, Julie, and thank you for coming to speak with us today.
So thank you for the opportunity and the invitation to both visit with you and meet with everyone today and to present. I'm very much looking forward to it. So today I'm going to cover some of the work that we're doing at the Vaccine Evaluation Centre, which is in Vancouver, British Columbia at the BC Children's Hospital. And there's 2 large surveillance networks that are housed at our data centre there. The first is the Canadian Immunization Monitoring Program Active, or IMPACT, which served as the model for the PEDS network here in Australia. So I'll present some information on that and give you sort of a brief overview of what the network does and a little bit of touch of the results and some of the things that we have out there. And then the second is the Canadian National Vaccine Safety Network. And this network does active safety surveillance primarily for seasonal influenza vaccines, but can be used for other new vaccines such as pandemic or the meningococcal B vaccine. So first I'm going to focus on IMPACT. So the origins of IMPACT were really back in the 1990s. There was a signal with one of our mumps vaccines that was missed by our passive surveillance system. We had an uptick in aseptic meningitis cases that didn't get picked up. And so it was really felt that we needed enhanced surveillance for vaccine safety in Canada, something beyond what we were doing with the passive surveillance. And the recommendation for this was to have this active surveillance based in pediatric hospitals across Canada. So in 1991, the CPS, our Canadian Pediatric Society Infectious Diseases Committee, which at that time was chaired by Dr. David Shifley, who's also started the IMPACT network, was asked to develop a proposal. So in 92, there was a pilot proposal that was put out for 2 years that involved 5 centres across Canada. And you can see the centres highlighted here on the map of Canada in blue. So Vancouver, Winnipeg, Manitoba, Toronto at Sick Kids Hospital there, Quebec City, and Dalhousie and Halifax. And so after 2 years, it was successful and the network was expanded to 10 centres. We added an 11th centre in about 1995, and by 1999, we had 12 centres and covered pretty much all of the provinces across Canada. And currently the network represents about 90% of the tertiary care pediatric beds in Canada and about 50% of the pediatric population. We do get referrals from all of the provinces and territories. So we cover some of the north. You'll notice there's not any, let's see if I can, here we go. You'll notice there's not any centers up here in the north, but we do get referrals down to the tertiary care hospitals from there. So how does it work? Basically, at each of the centers, we have a nurse monitor who is paid, and a pediatric infectious disease specialist who volunteers their time and works as the site principal investigator at each of our centers. So the nurse monitor will actively scan admission lists for any of the conditions that we have under surveillance. And at the larger center, the nurse may be working 5 days a week, but at some of our smaller centers, she's probably only there 2 or 3 days a week. So it's pretty much real time, but not always every day at all of the centers. So once a case is identified that might meet our case definitions, then they review the patient's chart as well as the vaccination record. And if they meet the case eligibility, then they capture information from the chart onto a standardized electronic form. And then all of the data comes to the data center in Vancouver where we process it. And then we provide the data monthly and quarterly to the Public Health Agency of Canada, as well as other investigators in the network who might be interested in looking at analyses, although that's done more on a more infrequent basis by request. So these are the targets that we have under surveillance. You can see the AFI, seizures, both febrile and non-febrile, and these are all admissions for our AFI targets. So encephalopathy, encephalitis and ADEM, myelitis, GBS, and other acute flaccid paralyses, thrombocytopenia, intussusception, and then any other sort of miscellaneous AFI that may come up that the nurse monitor or the investigator feels should get reported. And all of the AFI reports do go into the passive surveillance system. I'll show you some data on that in a little bit. So it's sort of identifying it actively, but then it does funnel into our passive surveillance. For our vaccine preventable diseases, we have the following: influenza, Haemophilus influenza. We are capturing all types, not just type B. Pertussis, varicella, zoster, invasive pneumococcal disease, invasive meningococcal disease, rotavirus, and starting this fall, so this past October for us, we did an RSV pilot. And I'm happy to take questions on that, but I won't be speaking too much for that other than to say it's been a lot of work. So I think it's important to probably note that, IMPACT was really set up to provide enhanced AFI surveillance, but because it was, involved a lot of infectious disease pediatricians as the investigators, they were quite keen to look at vaccine preventable diseases. And our vaccine preventable diseases was really added as almost an afterthought. The idea was, well, if the nurse monitors are searching for all of these AFIs, we might as well have them look for infectious diseases to kind of increase the yield from their work. And I think IMPACT is really probably best known for its surveillance on vaccine preventable diseases rather than its AFI surveillance. So it was a good thought to probably add that in at the very beginning, and it has certainly helped to make the network sustainable. So I'll show a bit of data on our AFI surveillance here. So this is looking at the reports coming into the passive surveillance system. You can see in the blue bar, those are reports going into the passive surveillance, and the red is showing the IMPACT reports. So on the first graph, you can see that IMPACT actually accounts for a very small proportion overall of the reports coming into the passive surveillance. So it's about 4% of all reports in children younger than 18 years of age. But when you look at the serious AFIs that are coming in, it's greater than 50%. That's the second graph that I have here. And for neurologic AFI, it ranges from about 70 to 90% of all the reports coming in. So it really is focused on these serious events and captures a lot of them that are reported in Canada. So we do have 15 publications on vaccine safety. We've got one that looked at the hazards of BCG immunization at birth in our Aboriginal infants and actually led to the cessation of that program in Canadian infants. We've shown the benign outcome of ITP after MMR. We've shown a reduced risk of seizures and HHE with the advent of acellular pertussis. I should probably point out IMPACT has been going on for about 26 years. So some of these go back a ways. The acellular pertussis vaccines were put in place in the mid-1990s. And as well, the absence of encephalopathy after acellular pertussis. We've calculated the post-immunization rate of GBS, and this had come up with some of our more recent influenza vaccines where there was a real question about, well, what is the actual rate? What do we see? When would we think something was above normal? And then we've evaluated more recently the Brighton collaboration seizures definition and exactly how that applies to surveillance. Those definitions really were created more for clinical trial research and have not been used much in surveillance. And we were quite interested in seeing, well, how well could you adapt them and do they work? So in terms of looking at vaccine preventable diseases and the impact of vaccine programs, we've got about 16 publications on Haemophilus influenza infections, about 7 on our influenza, 7 on invasive meningococcal, 10 on pneumococcal, 7 on pertussis vaccine and diseases, and 13 on rotavirus, varicella, and zoster. And I've put the list there in case, I'm not going to run through them all, but if you're interested, I would encourage you to check out the website. They're all listed there, and you can pull up the ones that are of most interest to you for both either the APHE or vaccine preventable disease. But what I will say is that many of our publications on vaccine preventable diseases were actually provided key evidence for the implementation of our vaccine programs, or key evidence in terms of the vaccine effectiveness. So I will show you a couple of data slides. I am an epidemiologist. So the first is the decrease in invasive pneumococcal disease from baseline, so prior to any conjugate vaccines in Canada, and then during the PCV7 era, and then during the PCV13 era. And I've not put years along the x-axis intentionally, because in Canada, all of our healthcare decisions are made at a provincial level, and so all of the programs started at different times. So it's quite challenging to try to look at data as you would normally like to look at it for epidemiologic studies. But what I really wanted to see was, well, what's the effect if we can really tease out the vaccine effect from these different eras? And in fact, we were able to. So we saw a 4-fold decrease in the incidence of invasive pneumococcal disease among children younger than 1 year of age, and a 2.5-fold decrease in children 5 to 9 years of age. And then as well with our rotavirus admissions, I think this is also an interesting slide to present, because again, this being Canada, we were able to sort of look at the initiation of vaccine programs at different time periods. So you can see that those provinces in blue that had a program by 2012, you can see the decrease in rotavirus admissions, in the incidence of hospital admissions. Those provinces with a program in red, you can see the decrease starting a bit later, and our 2 sites without a program as of 2014, you still see the increase. And we did have an 83% reduction at sites with the program starting in 2012. So there are some challenges as well as some limitations with this. It only catches the tip of the iceberg. It's either APHEs or vaccine preventable diseases that are severe enough to require hospital admission. So anything that's circulating out in the community that doesn't come into the hospital, we're not going to have. So it's really the most severe cases that we're seeing. Secondly, unlike in Australia, unfortunately, we don't have a national immunization registry, and that's probably one of the assets of IMPACT, because we're actually able to provide that information on our cases. But it is challenging to get this information. It requires quite a bit of effort from our nurses. So they either are following up with the family doctor, they're following up with the parents, or they're following up with public health, and sometimes they're doing all 3. And in rare cases, they're not able to track it down, but in most cases, we do get the immunization history. And then it's quite labor intensive. So on an annual basis, nurses will screen over 6,000 cases to identify approximately 100 to 120 reportable APHEs. So it is a lot of work. I think it was very smart for them to add in vaccine preventable diseases. It makes that workload a bit more justifiable, but it does take some time to do it. And so I wanted to touch a bit on our future. So we're in current contract negotiations for our next 5-year contract. The majority of our funding comes from the Public Health Agency of Canada. And we expect it'll be renewed, fingers crossed. They do get a lot of value out of the data we provide. We provide data that wouldn't be available in other sources. So I think that bodes well for us being able to continue. We've moved all of our reporting electronically, and it has taken quite a while. We've been electronic only for about 2 years. The system we're using is called DASAForms, which is a system that's based in Montreal, Canada. So it's sort of a local system, if you will, and we've been able to tailor it to our needs, which has been quite nice. But we still have a lot of sort of legacy data, so data from prior to when we made the switch that needs to be imported and matched to the data going forward. And so that's a big project that we'll be undertaking probably in the next 5 years. We do have additional targets that we're looking at, potentially Group B strep. There are some vaccines in the pipeline, and IMPACT may be a platform to look at that. And then also we may be continuing our RSV pilot. So one of the nice things that we've seen with IMPACT recently is that a lot of our, well, good and bad, I guess I would say, a lot of the original investigators who started IMPACT have reached retirement age and moved on to bigger and better things. But that's created the opportunity for some more junior investigators to become involved. And a lot of them are very enthusiastic about looking at the data, looking at additional side projects. So I think we may see some renewed activity and interest with some of our IMPACT studies. We do have about 26 years of isolates collected for invasive meningococcal disease, invasive pneumococcal disease, Haemophilus influenza. So there's a lot of opportunity to do some microepidemiology or genetic analyses with these isolates. And then we're hoping to get more student involvement. So Masters of Science, PhD, postdoc fellows. Again, lots of data and not really enough hours in the day to look at it all. So I'm going to switch now onto the Canadian National Vaccine Safety Network. And so this really came about because there was recognition that we needed more enhanced safety surveillance around our influenza seasonal vaccines, but also really wanted to have some infrastructure in place in the event of a pandemic so that when we were using a new vaccine, a new pandemic vaccine, we would have a way to evaluate it and monitor it a bit more closely. So some of the reasons for this as well, our influenza, back then the influenza vaccine clinical trials that they were doing only provided safety data on a small number of adults, and they were usually healthy adults. They didn't include children. They didn't include people with underlying health conditions. So not necessarily representative of the individuals who were getting the flu vaccine. And so the objective for Canvas is really to collect rapid safety data in various age groups for public health authorities on our seasonal influenza vaccines. We have used it during the pandemic, and we've also used it during a meningococcal B mass immunization campaign. It's really set up for any type of vaccine that's delivered in a mass immunization setting. It works well to collect safety data. So we have a network of about 40,000 participants, about 30,000 of those are vaccinated each year. And we have our annual control group of about 10 to 15,000 unvaccinated participants. So essentially our vaccinated participants from the prior year become our control participants for the next year. And this enables us to do some background rate calculation for events that occur commonly, and also enables us to be able to detect signals if we're seeing rates occurring more frequently in our vaccinated group than our control group. We did develop a mobile app to report health events after vaccination, but have had some resistance with people actually downloading it and using it. And we're finding that just emailing out the survey link tends to work better, at least for our study population. So the surveillance is in 5 provinces at sites such as hospital clinics, public health clinics, and pharmacies. Both our vaccinees are emailed an online survey 8 days after vaccination, and the control group receives that survey 2 weeks prior to the start of the immunization campaign in their jurisdiction. For both our vaccinees and our controls, they receive a reminder email 3 days after the survey goes out if they haven't responded. And then we do telephone follow-up of both groups for anyone who reports a medically attended event. And we try to follow up within 72 hours, but that does vary somewhat. So really what we're interested in capturing with Canvas are severe health events. So these are events that cause work, school, or daycare absenteeism, prevent their daily activities, or lead to a medical care visit. And so the question we ask of our vaccinated group is, in the first week, 7 days after your flu shot, did you have a new health problem, or did an existing health problem get worse? If they answer yes to that question, they're then asked if this health problem was severe enough to cause you to miss school or work or prevent your daily activities. And they're also asked if it led to a visit with a healthcare provider. So if they answer yes, that it was severe, then we go on and ask a series of questions about the event. Was it an injection site reaction? Was it vomiting? You know, how long did it last? When did it stop? What type of care did you seek? If they've answered no to that first question, no, I didn't have anything in the first 7 days, they jump to the end of the survey. We thank them for their time and they're done. So it kind of limits the amount of burden on the participants that way. And then our control survey is very similar, with the questions being asked slightly differently. Rather than 7 days after the flu vaccine, it's in the last week, did you develop anything? But then the skip patterns are the same as for our vaccinated survey, and the follow-up questions in terms of what the event were are the same as well. So in the last 2 years, we've started adding some questions on influenza vaccine during pregnancy. We recognized that we had volunteers who were pregnant who were participating in the survey, and we thought, well, I wonder if we could ask them about this, more specifically about this, to get at this. And we actually have been able to, and I'll show you some data on that, but it's part of the survey that I'm actually quite excited about. And so we asked them the general questions about, you know, was it an injection site reaction, et cetera, but we have specific questions if they say that they're pregnant on pregnancy-related events. So for both the vaccinees and controls, we collect information on stillbirth or miscarriage, preterm labor, preterm birth, high blood pressure, vaginal spotting or vaginal bleeding, or abnormal fetal heart rate. And the hope with this is really that it will enable us to do some background rate calculations for some of these pregnancy-related events, so that again, you could then see if with any given vaccine, whether you're seeing something going on in your vaccinated group. It's still very early days with this, but I'll be interested to see where it goes. Okay, so I'm going to show you some results for the last 3 years of the survey. So you can see we have 2015, we had just over 20,000 enrolled, and by last year we had over 40,000. Our response rate has averaged above 65% for each year that we've done the survey, and about 10 to maybe 15% of the participants are actually children. So we do get good numbers on children receiving the vaccine. Our control group is similar, although our response rate is slightly lower, a bit under 50%. But again, this is people who participated in the prior fall, so it's not too bad considering we've had no contact with them for almost a year. So the important thing that I always try to emphasize when I talk about this is the majority of our participants report no health events. It's a very safe vaccine. So it ranges from about, 90 to 91%, 89% in 2016 that said, nope, I had nothing, and they jump to the end of the survey and they're done. We get about 9 to 11% reporting an event each year, and the majority of those are reporting non-severe events. So it didn't prevent their daily activities and they didn't seek medical care. And I've kind of shown some rates on here in the vaccinees and controls. You can see that generally, depending on the year, it's slightly higher in terms of our vaccinees reporting non-severe events than our control group. So when we look at the severe events reported, so now these are people who said, yes, I had something that was severe enough to prevent my daily activities. These are the rates that we see each year. So it's about 3 to 3.5% in our vaccinated group. And we had a significant decrease in our vaccinated group between 2016 and 2017. When we look at it compared to our control group, you can see that we have some differences over the years. So in 2015, our control group was reporting more severe events than our vaccinated group, but in the last 2 years, we've seen more events in our vaccinated group compared to our control group. So you may be wondering what these events are. Well, I can tell you. So we've got primarily fever in adults. You can see the rate ratio here of 1.4. So it is significantly higher among our vaccinated group, both for adults and children. Headaches are reported more frequently in adults, systemic events more frequently in our adult vaccinees, and nausea, vomiting, and diarrhea. And these are numbers all from this past fall. Again, nothing that we wouldn't expect with the influenza vaccine, nothing that caused us any concern, but it's nice to have these data and to be monitoring this very early in the season. We generally get this report out within about 4 to 6 weeks of the influenza season started, the vaccination campaign starting each year. And we're monitoring it on a weekly basis and providing this information to public health on a weekly basis. So it's something of a finger on the pulse as it's happening. And it has been very helpful just in terms of when there have been potentially signals at a local level, we've been able to look at our data and see if we're seeing anything. So I'm going to show some results from the pregnant women in our survey because I'm quite excited about this. So they make up about 2% of women 18 to 49 years of age. We had just over 350 in our vaccinated group and just under 150 in our control group. You can see the breakdown by trimester here, fairly similar in both our vaccinated and control group. Again, as with our non-pregnant vaccinees, the majority are reporting no events. It was 90% in the vaccinated group and 89% in the control group. And of those that are for the 2 years that we've looked at this. So about 3 to 3.5% in the vaccinated group and close to 6% in the control group. And we've not had any pregnancy-related events reported in our vaccinees. We did have 1 miscarriage reported in the control group. So the numbers are small. Sorry, my text kind of overwrote here, but if you look at the number for each category in terms of the severe events, they're small. Wide confidence intervals. We're just starting this. Hopefully we'll get more pregnant women enrolled, but it's encouraging to me that we can actually capture this information in a fairly easy way. It's not requiring a great deal of resources to try to track this down. And if we can get the numbers up in these groups, we actually will be able to start really monitoring this a bit better, I think. So no significant difference. Anyway, so just in summary, Canvas provides enhanced safety surveillance for seasonal influenza vaccines and other vaccines, but they need to be delivered in a mass immunization setting to really make it cost effective. And it is, as far as I'm aware of, the largest rapid influenza safety surveillance on pregnant women. So I'd be happy to take questions.
Well, thank you so much, Julie. That's so exciting. We do have a room packed here, and I'm going to open the floor to a few questions. But I just wanted to draw, which I didn't do at the beginning, the similarities between Australia and Canada, because we really are, you know, Commonwealth countries. So we've just both competed at the not the Olympics, the Commonwealth Games. You have provinces and territories, we have states and territories. You have a large geographic mass, we have a large geographic mass. And I think there are so many amazing similarities. So, you know, obviously, as we're about to hear, PEDS has, you know, been related to impact, and it's fantastic to see that incredible, you know, amount of data coming out of impact. And I think we're going to be hearing some very interesting things with similarities about OZVAC safety. One question I had was, how do you know that your controls have not just recently had a vaccine?
Okay, that's a good question. So the way the influenza campaigns roll out in Canada are that the vaccine is centrally distributed. So we basically send the survey out before the vaccine gets distributed. So, I mean, theoretically, if they were out of the country, they could have been vaccinated, but the chances of that are quite low. And you know, we don't worry too much about it. I guess we could have a few controls that may have been vaccinated in that manner, but we're sending the survey out before vaccine is actually available anywhere. So we're pretty confident that we're not getting a mixed control group in there.
And so the only thing you might have as a difference there is maybe just a little time difference with respect to seasonality, maybe of coincidental respiratory viruses or...
Yeah. So it doesn't, it's not able to adjust for that type of thing. So there may be a difference of a few weeks, and sometimes with some of the, you know, viruses that circulate, that can be a problem. But we also have several years of data we can go back and look at to try to get a sense of what the background rates are looking like, and try to adjust for any of those types of trends.
Right, so the reason I'm passing this like a game show host is because this sound projects to our remote audience. So that's why we have to do this. Do we have any questions from the group for Julie at this stage? Yes, from Catherine.
Hi, I just wanted to ask, how did you decide on sending the survey 7 days after vaccination? It's like a little bit, you know, longer than, you know, like right after vaccination.
So I'm not actually sure. So we've been doing this since 2009. So I'd actually have to go back and look at what the original genesis of that idea was. And when we initially did it, we did it 7 days, 29 days, and then we did it 6 months. And that year was the pandemic year. And so we were really interested in longer term follow-up. And we do have the ability, if we were to see a signal, I didn't mention that, but we would have the ability to send out another survey at a different time point. If there was something that came up that we wanted to find out more about. But yeah, sorry. I can't remember why we chose 7 days.
Do we have any other questions? Penny. Can you shout out your question? I'll repeat it as well. Yeah.
Yeah, abnormal fetal heart rate, how is it defined? That's a great question, actually, because I should have mentioned that. So all of our survey responses are actually defined by the participant. So it would have to be something that, you know, the participant saw a healthcare provider and was told you have abnormal fetal heart rate. That's maybe an advantage and disadvantage of this methodology. You know, it's required us to keep the questions fairly simple. And when we initially started, it was given just to healthcare providers. So the language was a bit more healthcare provider-ish. And we realized once we broadened it out to children and other adults, we needed to simplify things a bit. So now it's really the individual judging it for themselves. It's self-reported.
And Clayton Chu?
Yes. So the question was, does an individual participant serve as their own control? And the answer to that is yes. So they are enrolled at the mass vaccination clinics when they're getting the influenza vaccine. And then we have permission to contact them for a second survey. That is the control survey that goes out then the next year before the vaccine campaign starts. So they are, in a sense, serving as their own control, although this will be, I don't know why we didn't do this sooner, but this will be the first year we're actually going to be linking responses. And so we'll be able to do even more analyses with the linked data.
But in the same year, they won't be a control?
No. So in the same year, it would have been the previous year's vaccinated participants. And there is some overlap. I think we do have people participating every year. Some people really enjoy it, but we also have new people every year. And it's given in different clinics, so it's not always the same group.
So is the age, I know you showed the percentage of children, is that, so with all the people involved, is it the age demographic
Well, that's a good question. Would probably, so the question was, is the age demographics enrolled representative of the wider Canadian population? And in some of our cities, for sure, there's probably about 10% who are in the pediatric population, and the bulk of Canadians are sort of aged between about 18 and 65 years of age. But in some of our other communities, it wouldn't be that representative. So it really depends on where geographically we're talking about. We haven't been so concerned about being representative that way. We've been more concerned about having enough enrolled in each age group to be able to look at specific effects in those age groups and specific vaccines, because we give a variety of different influenza vaccines in Canada, sometimes as many as 7. And so the idea is to sort of have enough getting each of the vaccines to really be able to pick up a signal if we would see one.
Great. Well, Julie, thank you very much. We're going to ask you to join us again at the end. But, the theme of our talk now is to hear about 2 similar networks in Australia. So it's my pleasure to introduce Dr. Phil Britton. Phil's a paediatric infectious disease specialist and a senior lecturer at the University of Sydney. He's just completed his PhD or I think, yes, it's soon to be complete, now completed PhD on childhood encephalitis, working with the PEDS network. And Phil is going to give, he's one of these, important, promising new younger investigators. I won't call him junior, but younger investigators who's helping to spearhead the work of the PEDS network. And so it's a pleasure to introduce Phil to talk to us today about the Australian PEDS network.
Thanks very much. There comes a time in your life when you're happy to be called younger or junior, sort of indefinitely, isn't there? And I'll take it as a compliment.
That makes me old.
No comment to that. So yes, I'm here to talk about PEDS, and that's been a fantastic introduction because PEDS was modelled on impact in Canada. So, we're all interested in vaccines here, and this is a kind of almost 200-year history of vaccines in a circle. I've highlighted here, the onset of variolation in Europe in the early 18th century, all the way through to meninge B and reverse vaccinology in 2013. And of course, there's subsequent history. I've also highlighted here in 2 stars when we've had disease eradication. The first in the 80s of smallpox, and then now we're on the cusp, as many of you will know, of polio eradication, we trust, in the coming years. And many of you will also be familiar with this schematic of the kind of story of a vaccine program where you have high disease incidence, the vaccine comes on board, you have control of that disease, but then there's this issue of maintaining both community and provider confidence that can wane, you get resurgence of the disease, and then eventually vaccine usage at a high level to achieve eradication. Now, these 2 diagrams are important for kind of giving context to my subsequent slides. Now, PEDS was started in 2007, and PEDS is an acronym for pediatric. We're interested in children under the age of 15. It's active surveillance in the sense that we're trying to find cases in the same way as they do in impact with our infrastructure, being nurses working hard in all of our sites. It's enhanced because we're collecting comprehensive and detailed data on these cases beyond what would normally be collected by a public health surveillance network. Obviously, we're interested in disease, though of course health is our ultimate outcome for our population. It's Sentinel Site, that's not included in the acronym, but it's very important. We're not population based, but a bit like Impact, we have broad population coverage. And in the same way as it's defined classically by the US CDC, surveillance is the ongoing systematic collection, analysis, and interpretation of data essential to the planning, implementation, yada yada, of public health practice. And so this is PEDS in Australia. You can see we're based in all the major population centres, in children's hospitals with a collaborative network of investigators, mainly paediatric ID physicians and general paediatricians. Again, Impact was the gold standard to which we move towards. And these are our conditions under surveillance with PEDS: acute flaccid paralysis, intussusception, varicella-zoster virus hospitalizations, pertussis, encephalitis in children, influenza, invasive meningococcal disease, invasive group A streptococcal disease, and for a period of time, febrile seizures in 2013 and 14. To give you a sense of the framework of PEDS, we are a surveillance network, and our ethics and governance approval is as a surveillance network to collect data on cases under a waiver of consent. So we don't necessarily have to approach participants. However, built on top of that is a research kind of program under 3 domains. One being outcome research. So if you have a severe disease under surveillance, we can follow you up down the track. For example, be that encephalitis, where we're looking at neurocognitive and neurodevelopmental outcomes of cases. There's also biological research, and that's similarly to Impact, where we're collecting specimens, usually pathogen specimens to do work on, but potentially, and has been in the febrile seizure context, host specimens to do research. And then also a third arm of research, which is social science and participant involvement research to understand their experience, both of the research itself, but also vaccine programs, etc. And then a further stream, which is emerging for PEDS, is the idea of evaluation of our own activities and understanding our impact in the public health sphere. And we report on a monthly basis to state and Commonwealth public health authorities. This is an example of the kind of report that's produced by our team here at the Children's Hospital at Westmead, which is essentially a case numbers, aggregated case numbers for all our conditions under surveillance. We also give a limited interpretation of disease activity and provide the raw numbers as well in subsequent pages of the report. Now, I want to really focus on giving you a bit of a taster of the impact of PEDS. And I'm a simple person, so I developed this schematic. It's totally original, probably not that helpful to anyone else, but it helps me think about things. So you can imagine when we're thinking about the use of vaccines in a country, the first thing that we want to understand is that there is a disease of public health importance. The second is that there is a vaccine, or there could be a vaccine, one in process. That's the example of RSV, for example. There is, or there could be, a program to deliver that vaccine. And in the delivery of that vaccine, the vaccine, we trust, will have desired effects, but it will also have adverse effects. We anticipate that with all vaccines, and with the ultimate goal of the disease being controlled. And this is reflected in that first schematic I gave you on the earlier slide. And of course, it's absolutely critical across that full timeline and experience within a population to maintain the system and provider competence and confidence and commitment to the vaccine, and also to maintain the community or the individual recipient confidence and commitment to the vaccine. So how does PEDS, where does PEDS fit within this kind of landscape? Well, that's what I'm going to present to you over the next few slides, some examples of where we fit and the impact that we've had. So the first kind of impetus for PEDS being created was polio eradication. So we're right down the end of the spectrum here of a disease that's controlled in the vast majority of the world now, but it's not controlled, or it remains endemic in 3 countries. And our job in polio control is to maintain certification that Australia is polio free. And the WHO mandates that we do that. And we do that by finding cases of a syndrome that is like polio. So that's called acute flaccid paralysis. And before 2007, the start of PEDS, Australia had great difficulty meeting the surveillance target, so identifying the appropriate number of non-polio AFP cases in this country. And what I'm showing you here is the impact of PEDS. And that is that we have been above the purple line, which is the surveillance target, since 2008, the first full calendar year that PEDS was in operation. And I think it's teal. That's right. The teal line, they're rising across the surveillance period, which is the contribution of PEDS to meeting that target. So PEDS now identifies well over 80% of all of the cases to meet our WHO surveillance target. So PEDS is essential. This is the point to Australia being certified as polio-free and meeting our WHO surveillance targets. Shift gear to another condition under surveillance. This is intussusception. Intussusception is recognised as an potential adverse event of rotavirus vaccination. And PEDS now has one of the largest cohorts of intussusception cases with clinical vaccine history and outcome. And we were the first country to demonstrate a low increased vaccine risk for intussusception nationally. And we subsequently confirmed that risk, and we showed that the adverse outcome, the risk of adverse outcome, was balanced by the impact of the vaccine on the disease for which it was attempting to control. So this is critical, isn't it? We're providing data that shows that the seesaw of risk and benefit in a population and at an individual level is in favour of benefit. And now we're in the process of analysing this cohort to show that vaccine-associated intussusception is no more severe than what you might call wild-type intussusception. And we can tell you that in excess of 14 intussusception cases occurs, but with the benefit of 6,500 fewer gastroenteritis hospitalisations in young children in Australia. Shifting gear again. You'll remember that we used to give MMR as one vaccine, and we used to give varicella vaccine as one vaccine separately. But the opportunity was there to consolidate that, deliver it as a single vaccine. But there was this concern of the febrile seizure risk that might be associated with this change. Now, of course, MMR is a much contested vaccine in the public space, and neurological adverse effects are right at the top of the population concern for this vaccine, irrespective of the truth or veracity of the claims. It's still a major concern for the population we're serving. So PEDS had the capacity to do work on febrile seizures to show the baseline risk of febrile seizures associated with MMR. And then go on to show that with the change in vaccine, there was no increased risk of post-vaccination febrile seizure at 18 months. And went on to show the improved vaccine coverage of MMR and varicella. So the critical thing here is that there's an absence of increased risk with the change in vaccine schedule, and there's an increase in vaccine coverage. So again, PEDS has that capacity to really define in detail that risk-benefit ratio for the individual and for the population. What about pertussis? Well, most of the people in this room would know that pertussis is our least well-controlled vaccine-preventable disease. But what has PEDS been able to do in this space? Well, the first thing is to collect detailed clinical data on hospitalised pertussis and really unmask the population at most risk of this disease, and also show that vaccine objection is a critical aspect of the disease burden in the population we're interested in. And in the process of doing that now, we're also collecting the first data on maternal vaccine effectiveness and calculating maternal vaccine effectiveness from maternal administration of pertussis vaccine in children under 2 months. Now, the numbers are small for that, but PEDS has the capacity to collect those data and calculate those things. So PEDS shows where are the gaps when you have a disease that's not controlled in the population, where are the gaps and what are the risks? And we also have the capacity to evaluate vaccine program approaches, different vaccine program approaches. And we have longitudinal data across different eras of different vaccine approaches for pertussis control. But PEDS also has the ability to unmask new population threats, so to define new diseases of public health concern. In October 2013, having just started encephalitis surveillance, there was an epidemic of parechovirus disease in New South Wales. And using PEDS, we were able to go on to describe the most severe end of that disease spectrum and its neurodevelopmental outcome. We've been then, since 2013, been able to be critical in defining 2 subsequent epidemic periods. Now, it might look in this slide like the epidemic was worse in 2017 versus 2015, but this is more about case ascertainment really than anything else. But we've been the network that's identified this epidemic disease. And as a result of this work and identifying this new threat, human parechovirus is now being considered as a possible condition to be added to the notifiable disease list in Australia. And what about flu? Well, PEDS has been critical to really defining the severity of flu in young children, including some of the more rare manifestations like flu encephalopathy and disease. And as a result, as many of the people listening today and in the audience will know, we're currently at a time where state funding for universal under 5 influenza vaccination is being implemented across Australia, almost across Australia. And PEDS has really been critical in advocating for this using data established from our network. So to go back to that simple-minded schematic that I gave you before, PEDS is looking at these conditions right across the full spectrum, from acute flaccid paralysis in the situation where you've got a disease that's controlled, almost eradicated, right all the way back to things like invasive group A strep and encephalitis, where we don't have a vaccine yet necessarily, but we're defining the population health risk of these diseases. In the middle, adverse events like febrile seizures and intussusception, through to program issues around pertussis and flu, etc. And we're really also increasingly trying to engage in that kind of population confidence by the way we communicate. And this is a nice little piece that Chris Blythe and Christine have just put together for the conversation on flu vaccine for under 5s. So obviously this is a massive network of people, and these are the investigators and the nurses who are the real resource that is delivering on all of this work, as well as our funders and partners. And I think I've used my time.
Okay, look, that was fantastic, Phil. In the interest of time, I'll just skip over questions for now. I do have to shout out to our New South Wales colleagues because they have actually published now the first study on pertussis VE in this country. So, so whilst PEDS was there, I think with a crude estimate, our colleagues in New South Wales have done a wonderful study on that. But I'm going to hand over now to introduce Miss Catherine Glover, who is a wonderful epidemiologist, and the theme of having some fantastic epidemiologists present today with our AUSVAC safety network. Catherine's based here. She does derive from the Northern Americas as well, but she's based here as one of our fantastic epidemiologists with AUSVAC safety. So I'll hand over to Catherine now.
Right, thanks, Christine. So I'm here to introduce AUSVAC Safety's active vaccine safety surveillance system, which we are running through across Australia. So AUSVAC Safety is a national collaboration of vaccine safety experts led by NSERS and funded on a multi-year contract through the Department of Health. And it's actually made up of 3 components, which I'll be talking about today is the Active Vaccine Safety Surveillance System. But OSVAC Safety also coordinates an APHI clinical assessment network, which brings together immunization specialists across Australia to assess and manage serious APHI cases, and also running a novel approach to looking at the safety of zoster vaccine using NPS medical insight data. So a little bit about the origins of OSVAC safety. Back in 2010, there was a significant safety signal in children under 5 receiving our particular brand of flu vaccine, which led to a nationwide suspension of the pediatric influenza program, and drop in vaccination rates the following year, and drop in confidence in the safety of the vaccine. The Horvath Review in 2011 recommended improved post-marketing safety surveillance in Australia, so several surveillance systems were established in Western Australia and New South Wales. And 2013 was the first year that NSEERS was funded to lead a pilot program study looking at the safety of flu vaccine in children. 2014 was sort of the first year that OSVAC Safety as an entity was formally established and funded by the Department of Health, continuing a focus on flu vaccine safety surveillance in children. And the next year, SmartVax joined as a surveillance tool, as well as STARS, which was great to have some more tools on board providing data so that we could expand in 2016 to monitor the safety of pertussis booster in children and zoster vaccine in the elderly, which were pretty big changes to the NIP in that year, National Immunization Program. Last year, we expanded influenza vaccine safety surveillance to include individuals of all ages, including pregnant women, which I'll talk a little bit about later. And this year is really exciting because we have just gotten an expansion to look at HPV vaccine safety, which is delivered via school. So it's really exciting time for us. And we're being kept really busy as well. So you can see active vaccine safety surveillance has really progressed over the last 8 years. In particular, the tools that provide the data have become less manual and more automated. There's been continued funding and expanded funding actually from the Department of Health. And OSVAC Safety altogether has really helped bring together vaccine safety collaboration and formalize it across Australia. So SmartVax is now the tool that provides about 95% of our data. So I wanted to talk a little bit about how it works. They conduct SMS-based surveillance. So 3 days after vaccination, SmartVax will send a text message to the vaccine recipient or their carer asking if there were any adverse events experienced. This message comes from the medical center. So in this way, SmartVax sort of helps the medical practitioner fulfill their duty of care to patients by following up with them. If you respond with yes, you did experience an adverse event, you'll receive a second message that asks if you presented to a doctor or an emergency department, as well as a survey that asks about for further information regarding the adverse event, such as fever, temperature, pain at the injection site. There's also a free text option, so you can kind of say if there were any other adverse events experienced, and you can select multiple adverse events. So these responses are collected by SmartVax and then sent to NSEERS for reporting and vaccine safety monitoring. So what makes our surveillance system so unique and sophisticated? Well, first of all, we operate nationwide. So we have over 250 Sentinel surveillance sites across Australia. These are operating in GPs, hospitals, councils, and also Aboriginal medical services. Our data are coming from Australians who are receiving the vaccine in a real-world setting. About 70% of people who are enrolled do participate by answering the first text message. And we hope that this participant-based data really improves consumer confidence in what we're doing. Our system is automated, so this text message gets sent out automatically. SmartVax runs in the background of medical practice software, and data are collected and retrieved in a very automated process. Our system also incorporates safety signal detection. So we have some clever collaborators in Western Australia who have developed advanced statistical techniques to monitor the safety of the vaccines, in particular looking at medical attendance as a proxy for serious adverse events. And they will let us know if these medical attendance rates reach unexpected levels. So all of this allows for our system to be using rapid and near real-time surveillance. The SMSs are sent just a couple of days following immunization. Those who respond do so within about 10 minutes usually, which is really great. So we're getting data back immediately. The data are analyzed and reported to the Department of Health on a weekly to monthly basis, depending on the vaccine, and the reports are kind of given on the right side just there. And we also post some broad overview data on our website so that consumers can also take a look at it. So what has our system told us about the safety of vaccines used in Australia? I have a graph here with the rate of any adverse event in dark blue and in light blue medical attendance for the 4 different vaccines of special interest that we are currently monitoring, and the number of participants who have contributed to each surveillance data set. At the top, you can see that the rates of any adverse event are well within expected ranges, which are be compared to clinical trials. It's usually much lower than anything found in a clinical trial. The most common adverse event reported across actually all of these vaccines is just injection site reaction, pain, swelling, or redness at the injection site. Especially with pertussis booster vaccine, which is the one that's approaching about 20%. But that's a known adverse event following pertussis booster immunization, so it is not unexpected. Importantly, the rates of medical attendance have remained quite low and stable over time, and those who do report seeking medical attention usually just go to a GP, so it suggests that their adverse events are not super serious. And looking at all of these data over the years that this has been collected, no safety signals have ever been detected to date. So I know a lot of you are probably thinking about the upcoming flu season, so I wanted to show a little bit more detail about the influenza vaccine safety analysis that we did last year, which might be informative for you guys. So in addition to our routine post-marketing surveillance, we were able to do a more in-depth, thorough analysis of the 2017 flu vaccine safety data, which was great because we had actually about 75,000 people participate. So really big numbers, really in large part thanks to the expansion of SmartVax across the nation. So really exciting data. And because our data is so high quality, that means we can also look at many different variables, including brand, the age groups, pregnancy, and concomitant vaccination. So this graph is really just showing any adverse event and a couple of specific adverse events compared across brands. And it's really great that our system was able to show that the safety was largely comparable between the 4 different brands of influenza vaccine used in Australia last year. We do see a little bit higher rates of fever and medical attendance reported by recipients of Flu Quadri Junior, but this is not really surprising because these recipients are all children under 3. We did notice an increased risk of reporting any adverse event by those who received a vaccine in addition to flu vaccine at their visit. So if someone received, for example, flu vaccine and zoster vaccine at the same visit. There was also a slightly increased risk of medical attendance in those receiving concomitant vaccine in individuals over 40 years old. However, the adverse events were still within expected ranges. All medical attendance rates were below 1.5%. And we expect to do some more thorough analysis of specific combinations of concomitant vaccines to kind of look at this relationship a bit more closely. Oh, and I just wanted to mention that we had about 2,000 women enrolled in our flu safety surveillance. So have to challenge your little your claim. Yeah. So to sum up, we have a really powerful active vaccine safety surveillance system in place here in Australia. And there's a lot we can do with it. We can actually understand some more about the uptake of certain vaccines like flu vaccine, which is not well reported to the Australian Immunisation Register for some groups. Our system is really flexible, so we can actually look at the safety of vaccines that have never been used before in Australia, so such as the Fluzone high dose. Those should be starting to come in about this week, so we'll be able to report next week on the rates of adverse events in people receiving Fluzone high dose. Our flexibility also means that we can monitor the safety of anything that changes on the NIP. So for example, men ACWI is being introduced at 12 months, and it'll be in combination with MMR. So we have the ability to look at safety of that kind of scheduled time point. We have the ability to look at an individual's adverse event experience over multiple vaccination counters, so we can gain some insight into if any adverse events are typically experienced by someone over time. And we do all of this in order to ensure the safety of vaccines used in Australia, which we really hope will increase public confidence in vaccination. So thank you for listening. I'd like to acknowledge everyone across Australia who makes AUSVAC safety possible, those pictured, and of course many more. Thank you.
That is fantastic, Catherine. Look, we are just right on time, but I'm going to take the chair's prerogative to just invite all three speakers to come up, Phil as well, and ask the audience if you have any particular questions. I'm actually, you know, I feel like we have almost needed longer because there's some fantastic systems here that are very, very complementary and interrelated. But I'll ask the group here first. Do you any questions? Okay, so I have one. You know, I'm really interested that here we have actually two novel vaccine safety monitoring systems. And Julie, maybe I can ask you a question hearing now what Catherine's told you. And I know that some of this information is probably relatively new, but, you know, what could we think about, you know, doing together or looking at? I mean, I'm really interested that you have a control group, which I did not realize was the case in Canvas. And, you know, as Catherine so nicely presented, we've done some work at looking at concomitant vaccines. Now, it's really important to emphasize, including to this audience and the wider group out there who I keep waving my arms to but can't see me, that, you know, even with 2 or more vaccines on the same day, our rates are incredibly low for any adverse event. So what you emphasize, which is, you know, overwhelmingly these vaccines show no reactions, is absolutely the truth. And we know how important concomitant vaccines are because you can't, you know, go back again and again to the doctor. So that's really important to emphasize. But really interested in your thoughts, Julie, about the system differences. And
well, I have lots of questions. So I'm hoping I get a chance to talk with Catherine later and can pick her brain a bit about the system here because it's really fascinating. But I think one of the areas that we're noticing potential signal, or at least we sort of saw it with our influenza vaccines last year, was with the flu quad in the pediatric population, particularly around the injection site reactions. We also did see it in adults, but much more so in the pediatric population, and would be curious if the products are at all similar enough, you know, to sort of maybe look at that a bit. And I'm curious if you're seeing something, or if you will see something similar this year. We've only been using the quadrivalent vaccine in our pediatric population for about 2 years. And really this last year was the first year that it was really used in a widespread fashion. And I feel like for this next season, we're going to really need to be monitoring it closely because it was very suggestive. And I'm not quite sure what's going on with it.
So Catherine may be able to comment on a paper done by Alexis Pillsbury that's been published in Vaccine.
Yeah, so Alexis found that there was actually no significant difference between trivalent influenza vaccine and quadrivalent in children. It was limited numbers of participants, somewhat limited compared to what we have now. But yeah, we're continuing to collect that data. We've not compared our 2017 data, quadrivalent data, to prior trivalent data. So it's something interesting that we could do. But yeah, I'm really interested to see the ways that we can, you know, collaborate. And if you see something in your system, come and check with us and see what we're seeing. That would be really great.
Okay, so we are actually 7 minutes over time. I haven't had a chance to pepper young Phil, as I'm going to call him now, with any questions, but I'm sure that will happen by the audience after we all go to lunch. So thank you particularly to those who've been joining us remotely. Thank you particularly to Julie, to Phil and to Catherine for all excellent talks. And please, for the audience here, feel free to stay for lunch and ask the presenters additional questions. Thanks, everybody.